started while they're still signing in. So we're going to get rocking and rolling. We've got a lot of slides to cover tonight, so we want to get this started. So as you can see, first of all, we're actually going to start out on the right-hand side. We're going to talk about some trends. Let's go to tread through some of the legal waters that we deal with on a daily basis. Guys, legal is becoming a big part of what we do, especially being in our documentation. I'm going to show you some statistics, and then we'll move forward with that. And then we're going to move into talking about seizures and using your MAD devices, and talk about when and why. This CE will go for 0.5 medical with the state, and for your national registry, medical emergencies, 0.5. And then it also covers with 0.5 with preparatory with the state, and then clinical operations on your national registry site. So we're keeping, like I said, keeping a tighter rein on that of what we need to be covering for you guys. So some of the objectives we want to talk about is we're going to explore the outcomes of 3 cases that are from EMS lawsuits. These have already been tried, and we know exactly the outcome of these. One was a transport, and the 2 others were refusals. We want to understand pre-hospital providers, the ways that we should avoid legal interventions and improve our patient care with refusals. We're going to talk about that. Then we want to go into seizures. We're going to talk about the GABA receptors, and we want to understand the difference between the medications that we have in our arsenal to take care of this. So the EMS perspective, at the beginning of this, guys, all of y'all got in this business is take care of people and to make them better. But part of us doing that is the documentation aspect of it. And so we want to talk about some of the things that we have to suffer in litigation. Who's testified here? How many folks have been to court and testified? Very, very few, okay? Very, very few on our staff. Guys, it's something that is not pleasant to do. But when you do it, you want to make sure your report can back you up. Because that's the only thing you're going to have there, and we're going to show you some of the things that they get pulled on a weekly basis. Every wreck is different. Every cardiac arrest has its own challenges. Every simple cough may evolve into 2 days and become pneumonia, and it may change. And so we need to be able to document these things, and it may be a whole different monster at the end of the call versus what started at the beginning of the call. And so at the same time, we want to be very professional with the way we present ourselves from a liability standpoint, and to take the risk away from yourself on top of our service and on top of Dr. Troutman. So we want to make sure that we're covering ourselves. Our patient encounters are not recorded. So we're not like the police department. We don't have the little video cameras. And when Bruce is talking ugly to me, I have it all right here filmed, and then I can go back and pull that and I protect myself. I don't. The only thing I have is my report. The only thing that I have is my report. Because guys, how many calls does each person run in a year? A bunch. So whenever you get called for that general fight that you went 29-1 with, that was just another call for you, and in 2.5 years later, it's going to court and they call you to testify, you're not going to remember it. The only proof that you have there is your patient documentation. So it becomes very important with the things we need to have in it. So out of 2014, we had an average of 70 UMC-MS patient care reports pulled every month. Of that, 62% were pulled by attorneys, 5% were pulled by the district attorney, and 29% was pulled by the medical examiner's office. The other 4 was pulled by physicians and other things throughout the hospital, whether it be M&M, trauma committee, those type of things, stroke committee, DNV surveys, those kind of things. So guys, lots of people are looking at your report. But what does this tell you? It's not about prosecution, it's about defense. It's about people coming in and saying, I'm suing Dr. Troutman for this, that, or the other because of this. That's what it turns into at the end of the day. So your documentation becomes very, very important. So the odds that you get a report, 70 reports a month, that's a pretty high number. That's a very high number. So it's something for you guys to think about. And let's talk about refusals versus no injuries. This is becoming a very big part of our business, and I'm going to show you some lawsuits that's going to tie this in. So first of all, let's talk about the N3s. N3, we all know, is something that we find. We see an injury or an illness, or we take a vital sign that's hypotensive or hypertensive, and we know you should go to the hospital, but you refuse any treatment or transport. That's an N3. And N4 takes that N3 and allows us to give some treatment. So I may fall and have a big cut, and I bandage it and I package it, and then I take it to the hospital, or I do not take it to the hospital, but I've done some treatment to you. That is an N4. N6 calls no injuries or suspected medical problems. And I want to talk about this suspected medical problems real quick, because what about if you're going on Avenue Q and an urban outdoorsman, I like this term, urban outdoorsman, has passed out in the middle of Avenue Q? You need to remain suspicious that there's an underlying problem. People don't normally pass out. Everybody agree with that? Everybody's normally conscious, alert, and oriented unless it's a Thursday or Friday night. And why are you giggling, PP? So normally people don't pass out, or people are not unconscious. So if we walk up and we suspect there's a synthetic drug on board, or a illegal drug on board, or a prescription medication on board, or an alcohol product on board, that is an induction of something's going on. They have consumed so much of that they're in an altered mental state at that point, and at that point that it becomes an N3 or N4. Now, they may refuse us to take vital signs and all. We're going to talk more about that. We witnessed syncope. I watched Bruce pass out, and then when the ambulance got there, he says, "Oh, I'm just fine." That's not an N6, because there was something there that caused that. No chest pain, because while I was sitting here, the chest pain went away while I was waiting on the ambulance. That does not classify as an N6. There was an injury. Why was the ambulance called to get you there in the first place? Refusals of transport is one of the most litigated things in the EMS world right now. More services are getting sued because of refusals than they are for transports. And how many refusals are we writing? We write a bunch a month. I guarantee it. We write a bunch. Instead of allowing a physician, and this is why it becomes litigated, instead of it was transporting it to the hospital and the physician come in and give all of his years of schooling to it, and we talk about our lab values and radiology and all the CT scans and anything else that happens, we don't have that. We're going off of what us paramedics learn in paramedic school and making a decision that it's okay for you to stay here at your residence. Now, I would probably venture to say across the board, most of our paramedics say, you need to go to the hospital. I see injury, I see illness, you need to go to the hospital. That's fine and dandy, but sometimes it may be the patient saying, I went to the Wiki School of Medicine and it's no big deal. My chest pain is no big deal. It is a big deal. Because you have to be able to cover yourself from a legal standpoint, along with UMC-EMS and along with Dr. Troutman. We've got to keep everybody covered here. Remember that pre-hospital diagnosis is very limited. You've got to protect yourself. Make every effort to do a complete assessment, including vital signs. If they refuse that, then document it. So if somebody's passed out in the middle of the street and I pull up and I give them a little sternum rub and they wake up all of a sudden, get up and take off and run, I need to document that. The easiest thing there is to say, we're clearing an N6. That's laziness on my behalf as a paramedic. Because what about if he runs a mile down the road, falls over dead, and then they call the ambulance and they say, well, the EMS was just there. The DA is going to pull that. And they're going to say, well, y'all found no injury. That's not a true statement. We had to wake him up with a sternal rub, but then he refused any further thing. But I can document he refused to sign, he refused vital signs, but I know he was obviously alert and fairly oriented because he jumped up and ran. I need to document those things as N3s. Spend the extra 2 or 3 minutes it takes to write that, even though it is that basically he's refusing all my services, but I need to cover that. And we've had an increase in that lately. We've seen these. Always search for an underlying cause. Explain specific risks that are not being evaluated by a physician. And do patient education at the same time. Also, try to establish them a support system. You know, if you're the second time over there today and she keeps falling, it may be the perfect time to say, hey, we've got people at the hospital that can help you get into a program to increase your strength. Or do you have somebody that comes and takes you? Ma'am, we're tired of busting down your door or knocking in your window, and you keep using your life alert. We got to find something that changes. Guys, we have a community medicine program that can help that. Also, the hospital has a system And the Life Alert system was very good, is it not, Hal?
Shut up.
If you didn't get to see the picture this weekend, please go to Facebook. Absolutely incredible. And we need to document these things in the report. We need to make sure that we're covering ourselves and make sure that we're talking about it in N3. You know, hey, Community Medicine Program was notified to help provide further education for this patient. Those are things that are going to help you cover because it shows you being a proactive paramedic or a proactive EMT instead of just going along with what happened and say, oh, it's a mid-6, we're done, we're clear. That's the easy way. But at the end of the day, that's going to give you more liability for if you ever get tried. So what about if we had this just the other day? Somebody fell. They did a great job covering the N3 and N4 on that because the next day somebody else ran over there, the patient was deceased. That is a huge liability on our behalf if we didn't document it. What about if that crew would have cleared on an N6? People don't just fall. I mean, sometimes we just trip and fall, and we can document that in those N6s that the patient just simply tripped and fell. What if we can't get vital signs? Dr. Hawley is the state of Tennessee medical director, and he says this about it. Even patients who refuse vital signs can be evaluated without physical contact. For example, a patient involved in an MVA who has no obvious signs of injury with minimal damage to the vehicle and refuses vital signs taken can be evaluated their competency through the simple observation and general conversation. So I could document so-and-so was answering questions. They answered everything that I asked, and they claimed there's no injury. They refused for EMS to allow any vital signs. That can still be an N6, but it's doing a better job of covering me, of saying, I tried to do a further assessment on this patient, and they refused that. They wouldn't let me do it. And so this is something that we need to cover ourselves with in order to protect yourself, our service, and Dr. Troutman. And we want to make sure we're covering those. So notable cases. Let's talk about a few things. This is Thomas versus Brandt. This is Miss Thomas and Mr. Thomas. They called Mr. Brandt and Mr. You want to help me out that one? Lair. Okay. So, and then against the community fire, and this was tried in Missouri. They called 911 and said that he was having shortness of breath. Mr. Thomas was having shortness of breath and chest pain. Paramedic arrived and the EMT arrived on the scene and did a focused primary assessment, and they did obtain vital signs. They diagnosed Mr. Thomas. With acid reflux and recommended that he get some over-the-counter Maalox and Gaviscon. The crew did not believe he was in any immediate danger and left the house 15 minutes later. If somebody else in 15 minutes, can you get a full survey? You bet. And they did. The next morning, Mr. Thomas called 911 again for worsening symptoms. A different crew came, treated him appropriately, transferred him to the hospital. He ended up having a huge PE. Although he was treated, he died later that day in the emergency department or at the hospital. Mr. Thomas's wife, so Miss Thomas, and the son filed a wrongful death lawsuit on the first crew due to alleged negligence from pre-hospital care. So at first, they won. At first, the EMS crew won. And they said because of sovereign immunity, that basically is what it says is at the end of the day, you're a government entity and you're excused. And we do fall under that in some circumstances, but not all. So as we move forward with this, it got sent to the appeals court, it got reversed, and they did find the paramedics negligent at that point. Because true sovereign immunity in a true emergency setting. So let's talk about that true emergency setting or not. Whether they choose or not, the crew had adequate time to assess the patient. We determined that. They determined that they could have performed EKG or other diagnostic tools, which the other crew did, and they explained specific risks for refusing transport. So that whether that crew talked that patient into saying, hey, you're okay, you can stay here, take some Maalox, take some Gaviscon, you'll be okay. But they may say, they may have not have thought about, let's do a 12 lead and check his heart real quick. So let's do a true scenario of a true emergent situation. Okay, the patient is only able, is alone and in severe respiratory distress, and is able to use the Life Alert button to push the call for help. The crew gets there, the patient can hardly speak. They have to successfully intubate the patient using etomidate and succinylcholine. They used Versed and fentanyl to follow. They used capnography. They did everything perfect. After the intubation, the patient started having peak T waves and ended up coding as the QRS complex widened because they now have hyperkalemia, which was caused by the succinylcholine. This is a perfect situation of where sovereign immunity falls into place. They didn't realize that the patient was a paraplegic because the patient couldn't talk and could hardly breathe at that point. So they did what's normal protocol for them. They followed it, and they did the emergent thing to fix that patient. They did not know that the patient already had hyperkalemia on a regular basis. When they gave the succinylcholine, it spiked it. They were not held at fault at that. This would be something that's true emergent. The folks that went earlier, they gave them the Maalox and Gaviscon, so that's their negligence at that point because they had the ability to do a further assessment and they did not do that. Talk about Schulman and the Los Angeles County Fire Department / paramedics. This is the case of just another drunk college student. So this young lady, Miss Sarah, decides to go out and she begins to have sudden ear pain, dizziness, nausea after she had drank 2 alcoholic beverages. How often is this we hear, I've had 2 beverages and I'm dizzy or I have a headache? Pretty regular call for us. They were at a small bar with their friends about 10:30, 22:30 hours. Her friends found her disoriented, vomiting outside, and unable to stand on her own. 911 was called. Sarah was outside covered in vomit. This is the drunk call, right? This is every Thursday and Friday and Saturday night for us. Her friend sat her up, described the chain of events of the evening, and to the fire department and to the paramedics. The emergency responders immediately concluded that she was drunk or using drugs. They did transport her to the hospital. Their field impression was alcohol intoxication coupled with a history of anxiety. The crew did transport her once again to the hospital, to the emergency room, and she was accepted in for observation. 22-year-old female just had a couple of drinks. That's a very standard call for us. She did not receive a CT scan for 3 hours and she was diagnosed with an intracranial bleed. Even though she was transported to the hospital, Sarah did not receive complete unbiased assessment because the paramedics on scene said she's just drunk. Take-home point is even an apparently intoxicated patient at 2:30 warrants a complete assessment. Okay, so we need to make sure that we're adding those things up. It may be they are just drunk at the end of the day, or intoxicated, or under the influence, but they can't say that synthetic marijuana did not push their pressure up and they popped a vessel in their brain and now they have a bleed. That has happened as of recently here, and our crew did a great job catching that. Next case was, and the paramedics did lose on that one also. This next case is Mr. Julio and Mr. Rodriguez. They decided to hold up a Freightliner truck at gunpoint. While in pursuit, Mr. Julio decided to jump out and run, and the police sent their canine officer, whether he was a dog lover or not. He did find him. He did secure him by the right thigh and drug him out to the street where he was detained and arrested. Medical assistance was called by the police, so they did their due diligence. They called. They did find multiple puncture wounds and stable vital signs. The wounds were thoroughly dressed, cleaned, and with sterile bandages, everything was documented very good, and the patient was still reporting some pain. Police maintained custody of him and took him to an interrogation room. This is where he said he was tortured by the police and he was prodded and poked with a baton, which made the wounds bleed again. After a flood of blood was formed in the interrogation room, this gentleman was transported to the hospital, received some stitches for a bite. So he filed a lawsuit against the EMS crew and the officers that they did act with deliberate indifference for serious medical conditions. The district court came in and said, no, EMS is not held at fault for this. They did a proper assessment, and they treated his wounds. They documented stable vital signs, and the bleeding was controlled and appropriate dressing. And they documented these things in a way, and they were released from the lawsuit. So you could see where this could go real easy, that I didn't document good, and it's going to keep me in that lawsuit. It's going to pull their service into the lawsuit. It's going to, because at the end of the day, are they going to come after me? I don't have anything to offer them. Who are they going to go after? University Medical Center, Dr. Troutman, because he makes all the money here. Okay? So they're going after UMC. So at the end of the day, that's what's going to happen. Now, we talked about sovereign immunity. Well, I'm a government agency. I'm relaxed here. Is this a case where sovereign immunity fell in? Absolutely not. Because I had time to do an assessment. I had time to do the dressing. I had time to do those things, so I've got a document to cover myself. Since he did have a serious and life-threatening, he was released back into police custody. Gross negligence could have been argued on the paramedics' behalf because they allowed him to go back into custody. This is something we see all the time. But the paramedics did the right thing. This was a gray area that they released him back into to the officer's custody. Guys, remember, most of our law enforcement officers are not medically educated. Very few of them have any medical education. So when we're getting them to sign the N3 form, part of your due diligence is, or your N4, is to say, if you see this, and this, it's no different than leaving them with a family member that's not medically educated. I need to inform them and document. I advise Officer so-and-so that I had, if he sees this, and this, it could possibly cause this and lead up to death. That's something that we've got to do a better job documenting to protect ourselves on our N3s and N4s.
Just a few quick comments. So, we can go dig through all these piles of cases, and it's scary looking at cases, right? And you can probably find a case, and some of you are looking at this thinking like, crap, I had that same case 3 years ago. I remember it well. So you can't let cases like this scare you. Who in here drives vehicles? Obviously everyone does, right? Every time we drive a vehicle, we're at risk at what? Having a wreck, right? If you buy a lottery ticket, you're at risk of winning. So part of our profession is we're at risk of being sued. That's just part of it. So, everybody that practices medicine has some chance of being sued. Not everyone will be involved in a lawsuit, but between this room, there'll be some folks that will be involved at some point. So, the big key is good care, good documentation go a long way, but really the best way to not get sued is to be nice to the patient. And that's been shown over and over. You can be the smartest guy, provide the best care, but be a jerk, you're going to get sued. You can probably be haphazard on your care and not always the brightest or the sharpest tool in the box, but a really nice guy, you're probably not going to get sued because you made the patient feel a certain way, like, I'm not going to, he was really nice to me, messed that up, that's fine, not a big deal. And that's been well studied, and you can read into that. So don't let lawsuits scare you, but it's just part of life, unfortunately. So we'll continue on seizures.
Okay, let's get mad with our seizures. Haha. Did good. All right, so let's talk about our seizures real quick. Pediatric population. Short duration, most of the time, it's febrile seizures that are prominent. These are things that are normally self-eliminating. These are normally things now, your family, especially your first-time moms and dads, they call you and they're scared absolutely to death. This is rarely turns into status epilepticus. Also, it's a very short duration of a seizure and typically is very treatable by acetaminophen and ibuprofen. So it shouldn't be that big of a deal, and just supportive therapy for that baby for that recovery period. Adults, on the other hand, tend to have prolonged seizure activity. As we get older in our life, it becomes a lot more. Chronic epilepsy, about 34%. Causes about 34% of our prolonged seizures. Remote sympathetic causes like brain lesions, tumors, that's about 24%. Cerebrovascular accidents, about 22%. Hypoxia and anoxia, about 10%. Metabolic causes, about 10%. And alcohol and drug withdrawal, about 10%. unless you're at Brian Payne's house, and then that may be a little bit more common, the DTs in the morning, but that's okay. So those are kind of the breakdown of typically what's causing the status epilepticus across the board. But our geriatric population, this risk goes up greatly. Even in death with prolonged seizures, about 38% of patients over the age of 60 and older experience prolonged seizures. Usually over 30 minutes will die. This rate jumps up to about 50% for patients over the age of 80. Okay, so that's a big part of our population. We all know that the baby boomers are growing, they're getting older. We're about to have a huge influx of our elderly population thanks to our baby booming population, and so therefore we're going to start seeing more and more of this. The younger population, though, doesn't mean they're out of the woods. At the same time, these younger patients can have continuous and long seizure activity. It ranges from about 14 to 22% in mortality. For prolonged seizures due to these complications. The complications, major causes of death include respiratory compromise, aspiration, hypotension through this process, organ damage and failure, and rhabdomyolysis in long term. So these young folks are still going to have these seizure activities on a long term. Not all seizures require pre-hospital medication, though. Most of them are going to be are going to be self-eliminating within 1 to 3 minutes. Okay, 1 to 3 minutes. How long does it take for somebody to call 911 and for you to be dispatched and get it around? That's probably 1 to 3 minute time frame. Okay, on a good basis. However, prominent organ damage starts after the occurrence of only 5 minutes of continuous clonic-tonic type seizures. So is what we're saying here. So we've got 1 to 3 minutes roughly for them to call, dispatch, get en route. How long does it take you to get there? Our average response time is just below 5 minutes, 6 minutes, 6 minutes or so, somewhere in that neighborhood. Now that's from the time of call to we're on scene. What time of window in we could be starting to have some organ damage at that point for the clonic seizures. Common sense would say if the patient is still seizing on EMS arrival, then that's pretty average, that they've been seizing now for at least 5 to 6 minutes at bare minimum. Probably closer to 7 or 8, maybe even 9 to 10 minutes at that point. So just depending on how long was the patient found immediately, were they walking, and then he said he had an aura, started seizing. You've got a lot of different things to look there. Seizure activity needs to stop. It needs to stop fast. Our protocols are very aggressive with our seizures, and that's why we went to the MAD device. That's why we went to benzos very quickly, to basically the biggest benzo we have nasally, which is Versed. The longer you wait, the harder it is to stop that seizure activity, and we're going to talk about that. So let's review it a little bit. A seizure, once again, is an erratic, rapid depolarization of neurons which cause the seizure. So the neurons, they start to rapidly depolarize very quickly. Specific neurotransmitters can prevent polarization of these neurons, while existing the GABA receptors that are there are key neurotransmitters. They inhibit the depolarization. This is important. The GABA inhibits the depolarization. On the other hand, the glutamate is the neurotransmitter that enhances depolarization. So if you think about it, at the end of the day, we start getting a tug of war. We have the GABA receptors going, we have our glutamate going, and this gives us our perfect balance to keep our neurons firing as they should. So at the end of the day, if I start to have any difference in my GABA or my glutamate, then that's going to offset that. It's going to cause one shift or the other, and that's where we get into our seizures. So if the glutamate wins, seizures may develop from rapid depolarization that spreads across the brain and CNS. But if we target the GABA receptors, and so we add something that's going to enhance that GABA receptor, it's going to pull that tug of war back and smooth it back out, and that's how our benzos work. So we have several GABA receptors, and they're benzos. These are medications at our disposal on the trucks right now. Onset and duration of action is affected by lipids and water soluble in each medication. So the Versed is rapid acting, but it has a short duration effect, but it can cause some hypotension here. But the nice thing is it has multiple routes you can give it. You can give it nasal, IM, and IV. So I've got lots of different options here of what I can get done. As far as the Ativan goes, and I'm a big Ativan guy, if I've got somebody with an IV currently, it takes a little bit longer for it to peak than it does the Versed, but it stays a lot longer in the CNS, so it smooths those neuroreceptors out for a longer period of time, so it allows that to stabilize with your GABA receptor and your glutamate receptors again. And then last but not least, but you do have less likely of hypotension with your Ativan. As far as your Valium is concerned, it can cause some hypotension like Versed can. It takes longer to take effect than your Ativan does. So it's going to be your longest one, but it doesn't stay around quite as long as Ativan does at the end of the day. If we allow prolonged seizures to continue, we all know that is what's going to happen. Our GABA receptors are going to retract. So after 5 minutes, if I've got some organ damage and my GABA receptors are retracting when I'm giving my benzos, is it going to work? No, because my GABA receptors are retracted, the Versed can't get to them. So back to the tug of war, it's very important that we spend time, we're very quick on how we stop our seizure, especially if it's a prolonged status seizure. Think of it as at the end of the day, back to the tug of war, I'm losing people on one end because my GABA receptors are retracting. And so I don't have enough recruitment of those receptors in order to accept my Versed to stop my seizure, to start plateauing that out. This is why we need to be very aggressive treating these seizures well before the GABA receptors are trafficking or starting to come back, withdraw back into the tissue. We need to be very quick with how we get this done. And so what this says is that basically at the end of the day is I don't need to move into a truck or I don't need to spend time trying to get an IV. If I get a seizure call, and I'm just going to be truthful, I get my seizure call, what do I take in? Most of the time I take my airway bag, because that's what I'm going to need, right? And so I tune in there with my airway bag, and do I have anything else with me? If I get in there and there's status Cs, I'm already way behind the 8 ball because now I'm 5 to 6 minutes, bare minimum, roughly, maybe up to 10 minutes, and there still continues to seize. Now somebody's got to go back to the truck and get the PRP, get the MAD device, pull your narcotics. That takes time. So what's happening with my GABA receptors at that point? They're starting to retract more. It's going to be harder to stop this. Nasal, the nice thing about the Versed, like we talked about, can be given multiple ways. It can be given IN, IM, and IV. But the quickest route for absorption is IV. We know that. But the next closest is the intranasal. 20 to 30 seconds in absorption. At that point, it peaks in about 5, and we're going to talk about that more. The thing is about the Ativan at the end of the day is probably a little bit better because why? It's going to last a lot longer and smooth those neuroreceptors out, but it's going to take me time to get an IV, to get it primed, to get everything in, so I may be a lot quicker going with my MAD device. So a quick breakdown, just a review here, this is for Versed. Intranasally, draw it up, attach the atomizer, and administer it. Onset of the effect is 2 to 5 minutes by the literature. The mucosas, some of the IN literature says up to quick as 20 to 30 seconds you're going to have absorption of that. It's a non-invasive route. It absorbs directly into the venous supply. But the other problem with it is if I have any nasal secretions, I'm not going to be able to absorb that as bad. And also it's going to be a little bit more of an irritant. pH of Versed is 3. So it's going to be a little bit of an acidotic at that point, so it could be a little bit irritant. Intramuscle, this is draw it up, attach a needle and stick it, not that long of a time. 80% peak after 5 minutes. Well, if I arrive on scene and I draw my stuff up, now I'm what, minute 12, minute 13 maybe? And now I add 5 more minutes and now I'm at minute 18. How long have they been without oxygen? A long time. And so we're waiting a lot longer with this. At the same time, rapid administration, the advantage is, I can stick it in the thigh, pretty open, pretty easy area. But at the same time, it's a slower absorption than the IV and the IN route. Plus, I have a dirty needle exposure. Once I pull out, and if the patient's still actively seizing, they may be moving around a lot. That could cause damage. At the end of the day, we know that this is a little bit of a delay on the IV because I've got to establish an IV, I've got to find an IV, establish it, draw it up. It may be 2 to 2.5 minutes on the onset. Most rapid route is established at this point. The only problem with it is it does take time to find that, find an IV spot and get an IV established. So we're delaying time. So at the end of the day, IN is going to be our total fastest route to get our seizure stopped with our benzos. So let's look at a few patient reports. This was a seizure patient. Patient's wife on scene stated he has a history of seizures and was very clear, very aggressive toward first responders in the past when he seized. She states over the past 30 minutes that he's had 2 seizures. So are we status at that point? Probably not. We're just in multiple seizures. But we do have some irritation there in the neural synapses. And so we do have something that's probably occurring, and they're probably going to have another seizure. States that last experience was approximately 10 minutes prior to EMS arrival was the last seizure. Wife denies any acute trauma, recent sickness, and I kind of got a kick out of this. That's on down here in just a little bit. We'll talk about that. So the patient is normal, conscious, alert, and oriented, able to answer all questions appropriately. She requests treatment and transport to the hospital to facility for evaluation. So as you can see, seizure history, and they've got everything set up, and they've even documented very well that the last seizure was 5 to 6 months ago prior to today. So they walk in, they finally get in there, and they get into the bedroom, and they see the patient thrashing around on the bed. He's combative, swinging his arms one way or the other. They're unable to tell, is it seizure or is he combative? So they make the decision to go ahead and use a sedative, use a nasal Versed at this time, and they got him all calmed down. He's sedated on the cot, doing well. Patients, this is a good spot right here where they talked about patient becoming a threat to himself and providers. You know, they said multiple times in reports they're unable to tell if this was seizure activity or him thrashing around like post-ictal rage. We do have some patients with post-ictal rage, and that becomes a very big problem for us. They did get a set of vital signs as best as they could for what they had to work with. They did note that the radial pulses were bounding. The rate was undetermined due to aggression. That's just fine. That considers a vital sign, tells me that you tried something. As we continue, patient continues to sleep and is stable. They did use capnography, something I wanted to point out. They did give a medication that could cause some respiratory suppression, so they did a nice job putting them on nasal cap in order to give us a number to prove that they were breathing at all times. Here's the Versed, nasal Versed. I'm sorry, do what?
Intramuscular.
I'm sorry, intramuscular. So they used intramuscular on this one. Versed administered for combative, sedative patient. There was unifocal seizure activity. Sedation effect was approximately 5 minutes after administration. So that falls in that literature window of saying it was fairly delayed. Now, they were not really sure if this one was combative or seizure, but they knew they had to take care of it, so they covered it with this one medication. Cardiac monitor, they finally got an IV, oxygen, did everything they should have. Continued from first patient assessment. Watched after the patient. They did a very nice job documenting everything that they had covered, and that the patient became verbally calm. Redirected the patient without the success. The chemical sedation was used for self-afflicting versus it could be possible seizure activity. So they did a very nice job documenting here of what we want to see. Report number 2 is patient is mid-20s. He skipped his Dilantin. Patient, once again, they were at work and he started vomiting. Patient said he was going to have a seizure. But he was trying to take his Dilantin. He hadn't been taking it. He decided he was going to take some. He couldn't get it in, and then began to have seizures. So they put him in a truck, tried to drive him to the hospital. He continued to seize. Finally, they said, you know what, we need to pull over and call 911. So the EMS crew arrived on scene. Patient was still having a seizure. His last one was approximately 3 months ago. and she denied, he's been skipping his Dilantin for the last few days. Arrived on scene for a passenger in the passenger seat of a truck. Patient was actively seizing, eyes rolled back in his head. After the administration of IN, Versed, that the seizures were resolved. Now it's kind of hard. I know we're kind of jumping back and forth because you have your assessments here and then your drugs given on the other side. So it's kind of hard to get to see them all in once. But the patient was answering some questions, so it kind of tells me, maybe a focal motor type seizure. But they were able to communicate some with him. He did express he did have a seizure history and takes Dilantin. Then he had to end up giving seizure was recurring again. They had to give another dose of Versed, the upper and lower body. Once again, they've done a nice job documenting. They suctioned the patient, very nice of them. Versed was given 5 milligrams IN, and then seizure activity stopped very quickly. Got him in the truck, cardiac monitor, IV, did a blood draw, then he began to seize again, so they ended up having to give, this time, IV push, so they were given time to get it, and they got this seizure stopped. The question is, right here, are you better off staying with Versed because you already have it drawn up, or are you better off going with Ativan? That's your decision. We give you the means to make decisions there, to make in the protocol to decide if you're going to stay with that benzo or if you're going to go with something else. And so, it's 50-50 here. I bet you people would probably, I would be more apt to probably go with Ativan if I had an IV, just because I know it's going to hang around a little bit longer. But if he's actively seizing right there, we've already been in a status seize. He may not have the GABA receptors. They aren't maybe retracted, so I need to get that stopped immediately. So I've got to that's a judgment call on your behalf. Once again, they suctioned him and did a very nice job documenting. Report of the month. 40-year-old a female in her 40s. She began to have a focal motor type twitching on one side of her body. States that it began and she appeared then they had a full body seizure. States that they had sent somebody to retrieve her husband. And the patient seized for approximately 5 minutes probably prior to calling 911. Okay, so we're already 5 minutes behind. Now we add our 6 or 7 minutes to it. Now we're in the teens, and we're before EMS is getting there. So we do know we could have some organ damage at that point. The crew was for a blank-year-old female who was found in the floor in the location actively seizing. The patient starts to actively seize again. The patient seizure stopped it finally at this point. And there's no really medication documentation because he's got it documented further on. It just kind of shows you a setup of what happened. Did a very good job here just documenting, hey, we had palpated at about 90. She's actively seizing at this time. Vital signs are not always going to be thorough and complete, but it tells me that at a certain time that we're moving forward with this, that they're making attempts to check to check vital signs at that point, and they did check a blood sugar pretty close, pretty quick in. Once again, followed up with vital signs. Very good job documenting no change in patient condition, still actively seizing, and they're giving medications you can kind of see here in just a second. So we've got IN Versed, IN through the MAD device. It was given, and it did stop the seizure for just a little bit. And then she began seizing pretty much immediately again. Now, we've already talked about we're 13, 14 minutes in. Is my Versed going to work? Maybe, maybe not. But it's the only option I got at that point because I've got to be aggressive and get it quickly. Once again, they used the MAD device because they still didn't have an IV. They did a good job getting 5 more Versed on. They got the seizure stopped, got her moved to the truck, cardiac monitor, got her on an IV, and then we began to seize again. So at this time, they decided to switch to something a little longer acting. You go into the Ativan. The husband states that she has no allergies to Ativan and that there's no change in the patient, or there was a positive change in the patient condition after the Ativan. So it shows that they used, thinking about it, and getting those things. But as have be it, prolonged seizure once again, she starts to seize. They give another dose of Ativan. What's happened here? This is the perfect patient that her GABA receptors are all retracted. She seized for a very, very long period of time. Sometimes you're not going to be able to break those seizures. Sometimes they may have to use other things like propofol at the hospital, which is some of the new stuff coming out that they're having very good success with in the emergency room for patients that have received large doses of medications. At very worst situation, if we can't stop a seizure, we're going to want to take that airway in a very, very distressed situation. If we take that airway, what is that patient still doing though? The patient's still seizing. Okay, so it's something we got to remember to keep that Versed on board if we have to take that. There's a fine line of where you get to that, and the bad thing is there's not a protocol that can teach you that. That's just something that's a very prolonged situation, because then they're going to start talking about using other drugs. Once again, they did a very, very nice job, very aggressive with this patient, getting Ativan on, getting Versed on by their MAD devices very quickly, being very aggressive with them, and then going with the Ativan. They're deciding one's not working, let's switch it up and try another, and it worked very good in this situation. So, John Groves got Report of the Month, so congratulations to John Groves for that. He's on a 2-week-long hiatus on vacation, so it's all yours.
Must be nice.
Yeah.
Hey, Janet,
Sir.
There's a handful of kids here in town
Yes.
that you walk in and these kids are status seasoned, and the parents tell you the only thing that will solve this is propofol. Should we even worry about trying to give these patients all this other crap if it's not working?
Yeah, I think we still should.
Okay.
You know, even if that patient comes before me in the ER, I think you got to be real careful just jumping to that end, you know, and a lot of times, especially those really the pediatrics that have some issues, the parents really know what works, and it's probably right, and that's probably where we're going to end up. I still think we got to kind of stair step that. And, you know, I'll walk up here. You know, propofol. And I think we actually talked about, should we carry propofol for these particular folks? It's isolated, you know, it's a rare thing for us to put propofol on every truck, so there's really not too much other utility that we could use it for. And propofol is really a newer adjunct to use for seizures, and it's kind of becoming, and I don't know if we're seeing more where the Versed and Ativan, things like that, aren't breaking some seizures, and so I don't know. But we're seeing occasionally have to go to propofol. You know, maybe someday we will see it more routinely used for EMS or more routinely given for seizures, but it's real particular to give it for those. But good question. So a few things. So febrile seizures, probably everyone in here has ran on a febrile seizure kid. You know, probably usually the worst part of that are the parents. You know, that's really your patient at that point. I have a son who he had a febrile seizure, and I went into daddy mode and I freaked out, and we called 911 and did the whole spiel also and rode in the ambulance, and then he was bouncing around, and we're like, God, why did we ride an ambulance up here? And they gave him some milk or something, and we went home and nothing was done, and he had a little otitis media. So the parents are really the ones, you know, the kids. Obviously, it's even scary as healthcare providers taking care sometimes of children when they're seizing, because we don't see it every day, but it is something that we see. So just remember the parents and try to calm them down, or have a partner calm them while somebody's tending to the child. You know, we've kind of, I think, beat the dead horse. Versed and Ativan, there's really not one that's superior. I think generally we probably more see Ativan given. Certainly in the ER, it seems like more pre-hospital more tends to give Versed. Again, I don't know that one's really better than the other. So intubation and seizures. So if it was an obvious seizure, you know, somebody calls 911, my brother had a seizure, he's kind of laying there, and you walk in and he's, you know, kind of snoring respirations. He's obviously postictal. And yeah, he doesn't take his Dilantin, or he doesn't this, or he has a seizure every so often. You know, you could make the case of, man, he's out of it, I need to intubate this guy. You know, because if this was any other situation, if they're that out of it, we probably would intubate. But if it's a really known seizure, you want to drag your feet a little bit. their GCS is probably less than 8. You could be justified for intubation, but likely what's going to happen is he's either going to seize again, or they're going to start to wake up as that postictal time wears on. And everybody in here has seen, postictal times can range from almost no postictal period to very prolonged, to like 24 hours, up to that type. So another one, we kind of started the conversation today on the refusal of transports. And I don't think we really touched on a patient that seizes and then refuses to transport. That probably happens, just like we see the diabetic is probably the most common one we see. But if we see somebody with known seizures, they've just non-compliant, or maybe they're compliant, even taking Dilantin or some sort of medication, it's not 100% that makes the seizures go away. Some people, you're just going to have seizures. And maybe they're at Walmart and they have a seizure and somebody freaks out, calls 911, they're like, man, I'm fine, I don't want to go with you guys, this happens every 6 months. You really got to document that closely. And the big thing is to document, tell them, and usually if they're known seizure folks, they don't drive. But you really want to tell them and you want to document. Because what can happen, and there's law cases we can find, somebody was seen in the ER, seen by EMS, had a seizure, was discharged, and they happened to get behind the wheel and they seized again and caused a wreck and killed somebody, and nobody told me I couldn't drive. In reality, probably somebody did, or they knew better. But if you were the hot potato holding the last one and you didn't happen to tell it, they can pin that on you. So it's real easy to throw in there. Do not drive until cleared by a physician. Before we get to that last one, we talked about, if we do intubate somebody, either for postictal or more, we think of the status epilepticus type patient. We intubate, we want to use short or long-acting paralytic. Short. Why?
So I can see them seize.
Right, because we want to see if they're still seizing. If we give them Rock or Beck or something where they're going to be paralyzed for an hour, are they seizing? Who knows? Unless we hook them up to an EEG, we have no clue. With sucks, if they're seizing, we get them down 5 minutes or ever till it wears off, we're going to know they're still seizing. And remember, we can still give Versed, Ativan, and things of that nature. So just remember that. And then, so who in here has not seen a patient with pseudo seizures? It gets frustrating, right? And it's those type patients we roll our eyes at. So-and-so called again. They're, oh my gosh, look, I'm having a seizure. And, it quit now. But if I walk over here, it starts seizing again. And we roll our eyes at it. But you still got to be careful of it. Because some of these folks, it may be an actual seizure coming on. Or some of them will have seizures with a pseudo-seizure component. So although all of us tend to roll our eyes sometimes at those patients, they still, that is a ICD code, that is a real disease process, and it can also mean they have true seizures too. So just, you got to remember, and we got to respect that, even though I know that it gets annoying sometimes. I think that was it. What's the next slide, please?
Okay.
Cool. Any questions? Awesome. Thanks.
Okay, so you know how we're doing it. We're doing the quiz. For the fire guys, we'll answer the quiz. We'll send you the sheet. We don't fill them out.